Today, we're looking at a huge challenge, ensuring every child in Nigeria gets those life-saving vaccines.
It really is. Millions are still missing out every year. It's complex, and it definitely needs some fresh thinking.
Exactly. And that's what we're diving into today, a powerful new approach. It's called the Geneva Learning Foundation's Nigeria Immunization Collaborative.
That's right. A big partnership, actually, with Nigeria's National Primary Healthcare Development Agency and the NPHCDA and UNICEF, too. The core idea is about unlocking the wisdom, the real know-how of health workers like you right there on the ground, the people who see the challenges and often the solutions firsthand.
Right. So our mission here is to unpack what this collaborative actually is, how this unique peer learning thing works, and crucially, what insights it's brought to light about overcoming immunization hurdles in Nigeria. We'll look at both sides, getting the services out there, the supply side, and encouraging people to use them, the demand side. And we'll keep the language clear, simple, focusing on what's genuinely useful for you if you're working in health at the local level, or maybe making policy decisions.
Yeah, and the power of this really is that it's a shortcut. It helps you understand what thousands of your colleagues across Nigeria have figured out works, not just in theory, but in practice. You know, one participant said they ended up being surprised at the answer I got when they dug into their local challenge. It really shows the answers are often closer than we think.
Okay, let's start right there. What exactly is this Nigeria Immunization Collaborative? What's the foundation?
Well, it's rooted in Nigeria's own plan, the Immunization Agenda 2030 IA 2030. That's the national roadmap. And this collaborative, it's this partnership between the Geneva Learning Foundation, NPHCDA, and UNICEF, all working together. Its main aim, to harness and share the practical, real-world experience of Nigeria's health workers to solve immunization problems directly. It's about empowerment from the ground up.
And the scale you mentioned, it's pretty remarkable. Over 4,400 health workers involved just weeks after the launch in July 2024.
It is. From all 36 states, more than 300 local government areas, LGAs. That's a huge pool of experience.
Wow. And a real mix of people, too, right?
Absolutely. About 61% were from the facility or LGA level, the front lines. We saw a good representation, 60% male, 39% female. And they came from different places, the Ministry of Health, various NGOs, and NPHCDA itself. Plus, over 600 organizations signed up as partners, so broad backing.
Okay, let's get into the mechanics. This peer learning model, putting the health worker, putting you in the driver's seat. How did this 6-week program actually unfold?
Right, it's quite a structured process, but it's built around the participant's own context. First step, you identify a key local challenge, something you feel you can actually help fix in your area.
Okay, a specific local problem, then what?
Then comes this technique called the 5 whys root cause analysis. It's simple but powerful. You just keep asking why about the problem. Why is this happening? Okay, why is that happening? And so on, about 5 times.
To really get underneath the surface issue.
Exactly, not just stopping at the first answer.
Yeah.
And the results were fascinating. About half the health workers involved discovered their initial guess about the main problem. Well, it was off base.
Well, half. That's significant. So they thought the issue was one thing, but the whys led them somewhere else.
Precisely. Maybe they assumed it was vaccine rumors, but digging deeper revealed, say, transport barriers were the real blocker. Or clinic hours just didn't work for working mothers. Once they pinpoint that deeper root cause, then they develop an action plan. But crucially, it's focused on practical things, feasible steps they can take locally, often with resources they already have.
And this isn't happening in isolation, is it? It's a very collaborative setup.
Very much so. It's all virtual, using straightforward tools like Zoom and Telegram, which makes it accessible. There are facilitated group sessions, discussions on specific themes, and this really important peer review part.
Peer review, how does that work?
Each person's draft analysis, their problem statement, their 5 whys, gets reviewed by 3 other participants, 3 peers. They give feedback, suggestions. It's not about criticism, it's constructive. And people found it incredibly helpful for refining their thinking. It builds that shared learning.
And there were experts involved too, but not dictating things.
Right, we call them guides on the side. Experts from TGLF, Nigerian experts like Dr. Abdulmaman Saad and Dr. Amaka Onobogu, global experts like Jenny Sakara. They offered guidance, asked probing questions, but didn't provide ready-made answers. The solutions came from the participants.
That sounds like a recipe for real ownership and critical thinking. What changes did participants report experiencing?
Huge changes. Many described a real shift in their thinking, a critical thinking evolution, they called it, moving from sort of vague problem ideas to a much deeper understanding. One health worker put it nicely, "I just discovered that over the years, I've been superficial. During the root cause analysis, I was able to identify the broader perspective and then fixing it.
Ah, it's powerful. And the peer review.
That really stood out too. People saw it as a practical learning tool in itself. It encouraged self-reflection, looking at your own work differently, and seeing how others approach similar problems. Someone even said, it made me realize I can be a team player.
And it broke down barriers, you said, between different levels?
Yes, that was another key benefit. It kind of dissolved the usual hierarchies. You had local health workers engaging directly, laterally, with state and even national-level people as peers. It fostered real teamwork, a sense of community working on shared goals.
And crucially, this wasn't just an academic exercise. It led to actual changes on the ground.
Absolutely. Participants reported making changes in their daily work routines based on their action plans. Some even started seeing tangible results, like improvements in vaccination coverage in their specific communities. It helped them see, as one person put it, how much I could do with what we already have. That's incredibly motivating.
And the sustainability aspect sounds promising, too. These networks continuing informally.
Yes, that's a really hopeful sign. The connections and the learning momentum seem to persist even without the formal program structure. It suggests this approach could really integrate into existing health structures for the long haul, building this internal capacity.
Okay, so we have this powerful model empowering thousands of health workers. What did they actually uncover? Let's dig into those insights now, starting with the supply side, the behind-the-scenes issues.
Right, and this was maybe one of the first surprises. While demand issues are huge, about a quarter of the challenges identified were actually on the supply side. Problems with getting the vaccines and services to the people.
Okay, so what were the main themes there? What sorts of problems and, importantly, what solutions came up?
Well, they clustered into about 6 key areas. First up was data collection and use.
Data. Always critical.
Always. The problem was often twofold. Either the data quality wasn't great or good data existed, but wasn't really being used effectively for planning and decision-making. The solutions proposed were very practical. Things like hands-on training in basic data management, setting up peer checks within facilities to catch errors, using mobile tools for faster data collection, and even developing simple frameworks to show colleagues the value of using the data.
Makes sense. Better data, better planning. What was next?
Second was vaccine availability at the actual service points, the clinic or the outreach post. The challenge here was stockouts or vaccines simply not being there when caregivers arrived, often due to weak forecasting or logistics hiccups. Solutions focused on improving stock management, simple systems, better tracking, training on logistics planning, and importantly, having a plan for when stockouts do happen, like proactively rescheduling appointments so caregivers don't just drift away.
Minimizing those missed opportunities. And the cold chain. That's fundamental.
Absolutely. That was the third theme. Cold chain adequacy. Lack of enough fridges, broken equipment, inconsistent power, the usual suspects. Solutions included, obviously, training on proper cold chain management and maintenance, regular documented equipment checks, and exploring innovative ideas like community-based backup storage in areas with unreliable power, keeping those vaccines safe and effective.
Okay, and you mentioned missed opportunities earlier. That came up as a specific theme.
It did. Number 4 was missed opportunities for vaccination, or MOV. This is when a child is at the facility for, say, a checkup or treatment for something else, but no one checks their vaccination card or offers needed vaccines.
Huge potential gain, right?
Exactly. The solutions were about systematizing it, developing clear facility protocols like every child visit includes a vaccination status check, training staff consistently, and appointing specific MOV champions within the facility just to keep it top of mind for everyone. We heard from Aliyo Ahmad Alhaji, who identified this as a key issue in his area, and his plan involved awareness campaigns and advocating for that formal facility protocol.
Great example. That's 4. What were the last 2 supply-side themes?
5th was an interesting one. Service quality that actually affects demand. This is where the supply side directly impacts whether people want to come back. Think about it. Inconvenient opening hours, really long waiting times, maybe unfriendly or rushed staff attitudes. These things put people off. Solutions here were about improving that experience. Training for health workers focused on communication and positive attitudes, looking at appointment systems, especially in busy urban clinics, to manage patient flow. Vivian Francis Odong noted this in urban areas and proposed appointments and maybe shifting some admin tasks away from vaccinators.
Right, freeing them up to focus on the care. So the experience matters just as much as availability. And the final supply theme?
Number 6 was missed communities. This is about entire groups being left out. people in very remote rural areas, maybe nomadic populations, or socially marginalized groups like families with disabilities. The solutions were really tailored, using mobile outreach clinics to get to those remote villages, doing specific advocacy visits to community leaders to ensure marginalized groups are included, arranging security for outreach teams in insecure zones, recruiting local volunteers to help map and reach underserved areas. Rebecca Bello, for example, had success using mobile units and making sure information was shared in local dialects to reach groups who were previously missed. Real grassroots problem solving.
That paints a clear picture of the supply challenges and the practical local solutions health workers came up with. Now let's switch gears to the demand side. This is where you said about 3/4 of the identified challenges fell.
That's right. And again, it's much more complex than just saying people are hesitant. It's about understanding the specific reasons why individuals or communities might not seek out or accept vaccines, even when they're technically available.
So what were the main categories of demand-side challenges?
We saw 6 broad areas emerge from the participants' analyses. The first one was service delivery barriers or practical access issues. This is about caregivers who actually want to vaccinate their child but face real-world obstacles. Things like not having money for transport to the clinic, not being able to take time off work, or maybe they had a negative experience last time and are reluctant to return.
So the intention is there, but life gets in the way.
Exactly. Solutions focused on overcoming these practical hurdles, maybe partnering with local motorcycle taxi drivers or community transport schemes, talking to communities to find clinic times that genuinely work for them, using community health workers as navigators and support figures.
Making it easier to act on the intention. What if the issue is less practical and more about perception?
That leads to the second area, no felt need. These are caregivers who aren't actively against vaccines, but they just don't see vaccination as a high priority compared to, say, finding food for the day or dealing with other immediate problems.
It's not top of mind for them.
Right, so the solutions here aimed at raising that perceived importance, identifying local vaccine champions, maybe someone whose child survived a vaccine-preventable disease to share their story, holding regular brief health talks during other contact points like antenatal care, creating mother support groups where vaccination becomes a positive social norm.
Okay, then we get into more active reasons for not vaccinated. What about fear?
Yes, the third area was active rejection due to fear of consequences. This is where caregivers are worried about side effects, even mild ones like a fever, or they've heard myths about vaccines causing infertility or other long-term harm.
A very common concern globally.
Indeed. Solutions here focused on transparency and managing expectations. Things like clearly explaining common minor side effects before vaccination, maybe providing simple info cards about what to expect and when to seek help. Some even suggested providing free paracetamol for potential fever. And for tackling the myths, it involves social listening, really paying attention to what rumors are circulating, and then engaging trusted local figures like religious leaders or respected elders to provide accurate information and counter the misinformation.
It takes specific, targeted responses. What about when the opposition comes from leaders or family?
That's the fourth area. Active rejection due to negative social norms. This could be opposition from influential religious or traditional leaders, or sometimes male heads of household who make the decisions about children's health. The key here is direct engagement. Proactively meeting with these leaders, providing them with clear, concise information and key messages they can share. And really making an effort to include men, especially young fathers, in awareness sessions and discussions. Gloria Anya in River State specifically focused her project on bridging knowledge gaps with these key leaders. And Dr. Agu shared a powerful story about showing photos of her own vaccinated children to counter conspiracy theories that personal touch matters.
Building trust through personal connection and engaging influencers, which links to the next point, I imagine. Lack of trust in the system.
Exactly. The fifth area was active rejection due to lack of trust. This could be distrust of the health workers themselves, the government, or even pharmaceutical companies. It's a fundamental barrier. Solutions here are about long-term relationship building, consistent, respectful engagement with communities, creating channels for feedback, maybe a simple suggestion box or a phone line so people feel heard, and health workers demonstrating trust by getting vaccinated themselves or vaccinating their own families publicly.
Actions speaking louder than words. And the final demand-side area.
The sixth was preference for traditional approaches. This is where families believe traditional remedies or practices are sufficient protection and that modern vaccines aren't necessary or might even interfere. Solutions often involved respectfully engaging with traditional healers, and particularly traditional birth attendants, or TBAs. Since TBAs are often the first point of contact for new mothers, encouraging them to refer mothers for immunization can be a very effective bridge, leveraging their existing trust within the community.
So 6 distinct areas, but underlying many of them seems to be this issue of misinformation and just general lack of awareness. How did participants tackle that pervasive challenge?
You're right, it cuts across many of the others. The exposure to myths, often amplified by social media, combined with sometimes limited understanding of how vaccines work and the diseases they prevent. The solutions here were really creative and community-focused. We saw ideas like organizing fun community events, vaccination festivals, as Udu Chibuke Agbadu successfully did to create a positive atmosphere around vaccination. Others focused on intensive house-to-house sensitization campaigns, using local drama groups to act out the dangers of diseases like cervical cancer, which Vivian Njoku did for the HPV vaccine, engaging local radio stations and trusted community influencers. And critically, developing information materials that are culturally appropriate and easy to understand, including pictorial guides for communities with lower literacy levels. It's about meeting people where they are, with information they can trust and relate to. And Ifeanyi success using confidential counseling and involving the father shows how tailored these approaches need to be.
This deep dive into the Nigeria Immunization Collaborative really paints a picture of transformation, doesn't it? It shows how these complex challenges often have roots deeper than we first assume.
It really does. And perhaps more importantly, it shows health workers that they aren't facing these challenges alone. There are solutions, often practical ones, using existing resources, being developed and tested by their peers across the country.
It feels like a new way forward, connecting people, breaking down those hierarchies we talked about, fostering peer learning. It all leads to these concrete, actionable plans.
Exactly. It highlights that the bottleneck often isn't a lack of knowledge overall, but finding ways to implement solutions effectively and adapt them to the very specific local context. That's where this peer learning shines.
And looking ahead, you can really see how these insights, this whole approach, could inform Nigeria's wider strategies for immunization and primary health care, can't you?
Absolutely. By empowering health workers, valuing local solutions, and nurturing this kind of peer-to-peer learning, Nigeria is effectively building a sustainable network of change agents within its own system. It's strengthening the foundations from the ground up.
The success here really underscores that incredible insights, powerful solutions are often right there within the communities, within the health system itself, just waiting to be unlocked.
It's about creating the right conditions for that knowledge to surface and be shared.
So a final thought for you, our listeners, reflecting on this, what local root cause might you uncover in your own work if you really push yourself to ask why 5 times? And what new action, however small, might that deeper understanding inspire for you?